Good morning, everyone. Welcome to Cleveland Clinic Tall Rounds. Today's Tall Rounds is going to be about the diagnosis of ATTR amyloidosis. We're going to start this Tall Rounds, as we usually do, with a case by our advanced fellow, Dr. Jeremy Brooks-Banks.
So let's get started with the case today. So we've got a 64-year-old African-American female who just has a medical history of hypertension, been relatively well controlled over the years. However, several years back in 2010, she had bilateral carpal tunnel surgery. And a couple years later, she tore a rotator cuff. Now she finds herself seeing cardiology in 2023, being evaluated for possible redo carpal tunnel surgery as part of preoperative evaluation. Her medications are listed below, and like I said, her hypertension's been relatively well controlled. You take a look at her electrocardiogram, not too much to write home about, normal sinus rhythm, but there is sort of, you can kind of get a sense of some lowish volumes and lowish voltages rather in the limb leads. You look back at an emergency department visit that she had for shortness of breath some time ago, and her NT-proBNP was 1,000, but she'd gotten sent home and no one really looked further into it. She had felt otherwise okay. Here's her echocardiogram that you obtain in the clinic. You see that her septum is a little on the generous side, and that the base of the heart doesn't appear to be squeezing quite normally. You see the septum is 1.2 centimeters with a posterior wall thickness of 0.9 centimeters. Remember, she is female, so that is abnormal. Here we see an apical four-chamber view where we can really appreciate that the apex of the heart has much better systolic function than the base of the heart does. And then we take a look at her strain imaging, and we see that the sort of classic bullseye pattern of apical sparing that we see often in cardiac amyloidosis. So unfortunately, as part of this echo, so it was actually ordered as a stress echo protocol because this was preoperative for surgery. There was some concern about possible lateral ischemia, which was called on this study, but wasn't called that there was some concern for amyloidosis. And this patient, you can see here, has a restrictive filling pattern at rest, which worsens with stress. And so she goes for her rotator cuff surgery, carpal tunnel surgery. Intraoperatively, here's the specimen. We see the H&E stain on the left with the extracellular protein deposition. And then we see Congo red stain over on the right with the classic apple green birefringence. Positive on pathologic specimen for amyloidosis, and then underwent mass spectrometry, which confirmed that this was TTR subgroup. Gets a pyrophosphate scan at that point, which is certainly positive. And then when you talk to the patient more and they actually end up in amyloid clinic, turns out her mother has known hereditary ATTR amyloidosis and had been followed at an outside institution for a number of years. She was positive for the classic genetic variant for this, had known evidence of AL on outside testing, but this case really highlights that there were many, many points in the cascade and over the years where this diagnosis could have been made, and finally was made at the time of a repeat carpal tunnel surgery. So lots to highlight in making this diagnosis as expeditiously as possible, especially now that we have treatments.
Very interesting case and highlights the importance of diagnosing this condition as early as we can. I'm going to move us forward with the overview of ATTR cardiac amyloidosis, pathophysiology, and types. And I think we should start with the definition of amyloidosis, which is a protein misfolding disorder. So normally our proteins are in a folded shape, and some proteins can pathologically misfold into more linear structures and then aggregate into these amyloid fibrils, which are rigid, non-branching, insoluble, and deposit extracellularly in tissues and organs, causing dysfunction. They have a characteristic appearance under electron microscopy, and regardless of the precursor protein that leads to the amyloid fibril, what they all have in common is when stained with Congo red and viewed under polarized microscopy, you get this apple green birefringent pattern. Now, although there's 30 different types of amyloid diseases, there's really two main types that affect the heart. You have AL, or light chain amyloidosis, which is a bone marrow plasma cell clone issue, or ATTR, or transthyretin amyloidosis, which is due to the liver-derived protein TTR. Either way, these amyloid fibrils deposit extracellularly between myocytes, causing stiffening of the organ. Now, although there are these rare other types of cardiac amyloidosis on the left, by the well over 95% of the time, it's either going to be AL or ATTR, and you should tailor your workup to these two types. So as far as the pathology of amyloid, the deposition is diffuse, affecting both the left ventricle and the right ventricle. The LV is typically non-dilated. Times there can be a small chamber leading to low fixed stroke volume. The atria are universally involved. You get direct deposition and thickening of the interatrial septum. You can impair atrial contraction. The conduction system can be involved. The AV valves can be moderately thickened. And in some patients, due to deposition in the intramural coronary arteries, you can get microvascular ischemia. These patients present to us with cardiac and non-cardiac clues. Cardiac-wise, most of these patients are going to present with dyspnea or heart failure. I put hypertrophic cardiomyopathy in quotes because this often can be the misdiagnosis. Low flow, low gradient aortic stenosis in the elderly, atrial fib or cardioembolic stroke, complete heart block, needing a pacemaker, and at times angina with normal coronaries. But there's these non-cardiac symptoms and clues that when seen in conjunction with a cardiac presentation can strengthen suspicion, in particular orthopedic manifestations, which we'll talk about shortly. So AL amyloidosis is a rare disease. There's about 7,000 cases, new cases annually in the United States. Median age of diagnosis 63, and historically has had a dismal prognosis when presenting with heart failure. That has certainly changed now. Nonetheless, it is a multi-system disease in which the amyloidogenic light chain forming the fibrils most commonly deposits in the heart and in the kidneys causes mainly glomerular disease with proteinuria, at times nephrotic. The other main type is not rare. We think it's more common than we previously thought, and that's ATTR or transthyretin amyloidosis. Now, transthyretin is a liver-derived protein. When it's secreted by hepatocytes, it is a tetramer, 4 identical monomers, and ultimately, either due to aging or some destabilizing mutation, this tetrameric structure can dissociate ultimately into the monomers, which misfold, aggregate into amyloid fibrils, which ultimately deposit in the heart and or nerves. And the neuropathy is peripheral neuropathy and autonomic neuropathy, and of course, orthopedic ligaments and soft tissues. Now, within transthyretin amyloidosis, there's 2 subtypes. One is wild type. In this type, there's no mutation in the TTR gene. It is not hereditary. Median age of diagnosis is in the mid-70s, most commonly white males, and it's much more common than we once thought. We believe that up to 10% of patients with HFpEF and increased wall thickness actually have TTR cardiac amyloidosis. The other is the variant type. In this case, there is a mutation in the TTR gene that causes a single amino acid substitution. It's hereditary, autosomal dominant inheritance, and the age and the organs involved depends on the specific variant. The most common variant in the United States is valine 122 isoleucine, which is seen in African Americans and causes late onset cardiac amyloidosis. The only way to distinguish these two is by a simple blood or saliva test, TTR gene testing, to determine if you're wild type or variant. Now, we always teach the fellows to ask these questions in patients with heart failure, increased wall thickness. Has the patient had carpal tunnel syndrome, typically bilateral, or surgery, spinal stenosis, biceps tendon rupture, or rotator cuff tear? This is because these soft tissue and ligamentous issues often present sometimes years before the cardiac manifestations. This is an example of a old ruptured biceps tendon in a patient with wild-type TTR. Probably about 30% of these patients have this if you ask, and probably up to 40 to 50% have carpal tunnel and spinal stenosis. As far as the variants, there's been over 150 mutations described. There's several that cause mainly cardiac, several that cause mainly neurologic manifestations, but most are a mixed phenotype. The one you should be aware of is the valine 122 isoleucine variant. 3.5% of African Americans are heterozygote carriers for this, putting them at risk for late onset cardiac amyloidosis. And then there is this Irish mutation. Unfortunately, you'll see in some of the reports V142I because they added a signal peptide. So hopefully you'll recognize that's the same variant. So it's the echo that prompts the suspicion. What we're looking at is increased septal and posterior wall thickness, amongst other findings. Typically, we start to suspect amyloid when the septum and posterior wall are equal to or greater than 1.2 centimeters. We typically have heard that this is a disease of HFpEF, but actually many of these patients have mid-range EF, and about a quarter of them can have lower EF. Other echocardiographic clues include thickening of the right ventricle, so biventricular thickening is a very important finding, pericardial effusion, thickened mitral and tricuspid valve, thickened interatrial septum, low stroke volume, and of course, due to the stiffening of the myocardium, varying degrees of diastolic dysfunction and restrictive filling. The other clue can be found on longitudinal strain imaging. Here we're looking at deformation at various segments of the left ventricle, and the strain, longitudinal strain, is near normal or less involved in the apex than it is at the mid and base progressively. So when you look at the polar map, you'll get this apical sparing pattern or bullseye pattern, which can be highly suggestive of cardiac amyloid. And when you look at strain and hypertrophic cardiomyopathy, typically it's reduced at the septum. In hypertensive heart disease, you typically will not see apical sparing. So this can be a very useful clue that you're dealing with cardiac amyloid. As far as the electrocardiogram, we always say look at the electrocardiogram in conjunction with the echocardiogram. What you're looking at is decreased voltage as opposed to increased voltage when you see in true LVH. This is the classic low voltage EKG that you see, less than 5 in the limb leads, and pseudo-infarct pattern. But the truth is only about 30% of patients with ATTR meet low voltage criteria. And in fact, LVH criteria in EKG is seen about 10% of biopsy-proven ATTR. What you're really looking for is the discordance between the voltage on the EKG and the degree of LV wall thickening. And conduction disease is very common, typically a first-degree AV block or an IVCD, right bundle, left bundle. When you look at the whole picture, this conduction disease can also be a clue. Two phenotypes to be aware of. About a quarter of patients with wild-type ATTR cardiac amyloidosis have asymmetric septal hypertrophy, and a small subset of those can have dynamic LVOT outflow obstruction. And then you'll hear a little more about low-flow, low-gradient stenosis in the elderly. Concomitant ATTR can be seen in 10 to 15% of patients. So the traditional diagnostic approach used to be to go directly to a heart biopsy. You determine if they have amyloid, and you determine the type. Heart biopsy is a procedure through the right internal jugular vein. We take about 4 or 5 pieces from the intraventricular septum. We quote a risk of less than 1% of RV perforation and tamponade. I think it can be very safely done in the right hands. And what you see on the H&E is these pink amorphous areas are the amyloid, and the other areas is the myocytes. Here we have 2 renowned pathologists, Rene Rodriguez and Carmela Tan, and they use thioflavin S instead of Congo red. They feel it's more sensitive and specific. This very light blue is the amyloid. But it's very important for a pathologist not to stop and just tell us there's amyloid in the heart. We need to know the type. We can either use immunohistochemistry, and when it's unclear with immunohistochemistry, we send it for mass spectrometry, and we do that in-house here at the Cleveland Clinic. Luckily, most of the cases, you can arrive at the diagnosis non-invasively with a constellation of labs and imaging findings. And at this point, I'll turn it over to Dr. Kwan to talk about cardiac MRI.
So I'll be talking about cardiac MRI for the assessment of cardiac amyloidosis. We'll talk about how CMR can be used to diagnose and follow up patients with cardiac amyloidosis and the prognostic impact of CMR evaluation for patients with cardiac amyloidosis. So CMR provides a really vast and comprehensive assessment of the heart. You can see all of these different imaging sequences here that all can be available in one single cardiac MR. And in terms of cardiac amyloidosis, really assessing the LV and RV size and function, mass, as well as strain and deformation assessment. But really the gold standard assessment for tissue characterization is cardiac MRI. One of the really important things that cardiac MRI can provide is the assessment of late gadolinium enhancement. And the pattern of enhancement can be very important for understanding the underlying etiology of heart failure in patients who are referred for a cardiac MRI assessment. So as you can see here, this panel here demonstrates a normal cardiac tissue characterization, where you can see that the normal myocardium here is this charcoal, almost black-gray. In patients with hypertrophic cardiomyopathy, you can see that there's left ventricular hypertrophy and areas of enhancement. And delayed cardiomyopathy, myocarditis, ischemic cardiomyopathy, and other various forms of cardiomyopathies, there are characteristics, delayed enhancement patterns. And in cardiac amyloidosis, this demonstrates a very characteristic pattern of abnormal gadolinium kinetics as well as diffuse gadolinium enhancement. And as we mentioned before, higher up the food chain, patients present with heart failure symptoms and are often diagnosed with HFpEF initially. And these patients can be referred for various testing afterwards. And in this study demonstrating that patients who are referred for cardiac MRI, significant number of patients are then further differentiated into either microvascular dysfunction, hypertrophic cardiomyopathy, constrictive pericarditis, or cardiac amyloidosis. And it's important to note that patients with echocardiographic findings of left ventricular hypertrophy, there are different types of underlying etiologies, which we can call phenocopies. So patients with Anderson-Fabre's, Danon's disease, cardiac amyloidosis, athlete's heart, hypertension, hypertrophic cardiomyopathy can all potentially look similar on echocardiography. But when you do the delayed enhancement assessment in these patients, there can be very different patterns of enhancement, which can really help to delineate the underlying etiology. So this is a prototypic characteristic finding in a patient with cardiac amyloidosis. You can see here there's diffuse left ventricular hypertrophy or increased wall thickness. And when you do delayed enhancement assessment, you can see that there's diffuse enhancement throughout the cardiac chambers, not only the left ventricle, but also can be seen in the right ventricle and also the atrial chambers. This is very sensitive and specific and provides a very high negative predictive value. But I think it's important to note that now that cardiac amyloidosis is becoming much more recognized and we're finding it much earlier in the disease course, this characteristic finding of diffuse delayed enhancement is not always seen because we're seeing patients with normal LV thickness. So the other characteristic findings with cardiac amyloidosis besides delayed enhancement is T1 abnormalities. So this is, and it's really important to demonstrate that the same degree of left ventricular wall thickness increase can result in very different tissue characterization and morphologies within the left ventricle. So you can see in this patient in panel A versus panel B, very similar left ventricular hypertrophy. However, you can see that the T1 mapping is much higher in panel B versus panel A. And similarly, the diffuse enhancement is much more prominent in panel B versus panel A. ECV, which is the extracellular volume assessment, is much more increased in panel B versus panel A, suggesting much more amyloid deposition in patient B. And also interesting with cardiac MR, you can also assess the perfusion of these patients. As Dr. Hanna had mentioned, there can be microvascular deposition of the amyloid fibrils. And with quantitative perfusion, you can assess this with cardiac MR. And this patient in panel B had significantly decreased perfusion compared to panel A. So in a single patient with a similar degree of left ventricular hypertrophy, there actually can be very different amount of amyloid deposition, which cardiac MR can help to delineate. There are different patterns of LGE in cardiac amyloidosis, really depending on the extent and the time course of the disease. So early on in both AL and ATTR amyloidosis, there can be no LGE if you're catching them very early. This progresses to subendocardial late gadolinium enhancement and then becomes transmural later on in the course. This is very important in terms of prognosis. As you can imagine, the more amyloidosis deposition there is, the worse the prognosis. So patients with transmural LGE have worse survival in both ATTR and AL amyloidosis. This also helps to demonstrate the importance of T1 mapping. So LGE really helps to identify patients with very focal or distinct areas of amyloid deposition, but sometimes in patients who are earlier in their disease course, it's much more diffuse and much less prominent. And so you can see in ATTR patients, up to 15% of them may have no LGE, but their T1 mapping will be abnormal. So T1 mapping is really a tool that we can use that's much more sensitive than LGE. This was a really beautiful study by Mariana Fontana's group demonstrating the different phenotypes in cardiac amyloidosis. And she looked at patients with different PYP grades, grade 1, 2, and 3. And obviously, grade 2 and 3, those patients definitely have ATTR amyloidosis. However, she looked at grade 1 and compared those with ATTR amyloidosis versus AL or apoprotein variant. And you can see here again, there are patients with no LGE, but then you can see patients with increased ECV and more diffuse LGE and increased ECV and the serine 77 variant, demonstrating that patients with certain types of ATTR amyloidosis or earlier in the disease course, cardiac MR can be sensitive in picking up these patients where it may be missed with PYP. So definitely PYP's strength is the diagnostic ability to discern AL versus ATTR. But in those where the PYP scan is not definitive, cardiac MR can pick up patients with cardiac amyloidosis. The other thing that was very interesting in this study demonstrated that the ECV, or the extracellular volume quantification, in ATTR amyloidosis increases as the PYP grade increases. As you would imagine, there's increasing deposition. However, with AL amyloidosis, the amount of ECV increases the same across the board, whether it's grade 0 versus grade 3. And really, in the grade 1 category, patients with decreased ECV are more likely to be ATTR amyloidosis versus AL amyloidosis. So this is a nice diagnostic algorithm demonstrating that patients who have symptoms of heart failure, syncope, or bradycardia, echo and cardiac MR can be a great first-line test. And a PYP scan is really important, therefore, for then determining the underlying etiology or their subtyping. And this definitely has to be also done in context of blood sampling with the AL amyloidosis labs. There was this really nice study done recently by the University of Chicago group, which was a multi-center study demonstrating that there may be some potential for subtyping with cardiac MR. And basically, this group demonstrating that if you have typical pattern of CMR LGE as well as abnormal gadolinium kinetics. If you take this in context of negative light chains, the specificity for ATTR amyloidosis was actually quite good. If you have positive light chains, that doesn't necessarily completely rule in AL amyloidosis. As we know, patients with ATTR amyloidosis can also have positive light chains. But in the setting of negative light chains with a very typical CMR pattern, this could be very specific for ATTR amyloidosis. I'll just round out very quickly a case. This is a 71-year-old male who had CABG, remote paroxysmal AFib, carpal tunnel disease, who presents for echo, found to have moderate dysfunction, severe atrial enlargement. By MRI, we demonstrate that there's not significant LVH, but very subtle pattern of LGE. The ECV was somewhat increased at 31%, but not as severely as typical, which is the threshold is 40%. But the PYP scan in this particular patient was negative, and basically then went on to have endocardial biopsy, and this came back positive for PYP. Again, demonstrating that we're finding these patients much earlier in their disease course as before. So just a quick word on aortic stenosis. Cardiac MRI can be very important in this population because, again, LGE can be a sign of increased risk. And basically, in ATTR amyloidosis, as well as AL amyloidosis, the most important prognostic marker is ECV. The higher the ECV, the more risk because it's identifying patients with increased amyloidosis burden. So in terms of progression and treatment response, cardiac MR can also identify patients who are responding positively to treatment. This is a really nice case of a patient who was given chemotherapy, and you can see a significant regression in the LGE as well as the ECV in patients at baseline versus 18 months. This can also be seen with patisiran as well. And finally, a change in ECV can have a really important impact on prognosis, especially as we're starting to treat these patients. Those who have progressive ECV increase have worse prognosis compared to those who have a stabilization or a decrease. And this is really a nice way for us to determine response to therapy. So in conclusion, CMR plays an important role in characterizing the extent and disease of cardiac amyloidosis, which provides important prognostic implications. While CMR does not reliably subtype ATTR in isolation, CMR offers increased sensitivity to myocardial infiltration, differentiating phenotypes as compared to PYP, and CMR provides the ability to track progression of disease or treatment response. Thanks so much.
Great, thank you. So I'll talk about how we can make the diagnosis with nuclear imaging. I'll start out by talking about the basics of cardiac scintigraphy, how we make the diagnosis, what some of the terminology you may see in a report means. I'll then transition to how we make a non-biopsy diagnosis, and then spend the last minute or two talking about this special group, which is this overlap between aortic stenosis and amyloidosis. So you may hear a couple different terms that all tend to mean the same thing. Kind of the older term is called a bone scan. That's because this test originally was a bone scan and still used as a bone scan, but radiologists long ago had noted some people had uptake of the tracer in the heart, and eventually that was linked to cardiac amyloidosis. Now, it seems kind of weird to order a bone scan for a heart study, so now the term we like to use is cardiac scintigraphy. But the term that you may also hear is pyrophosphate scan or PYP scan. And the reason why is because the tracer we use here in the United States is technetium pyrophosphate or PYP. But you may also see HMDP or DPD. Those are tracers used in Europe or other parts of the world. So you may hear me interchangeably use PYP scan or cardiac scintigraphy. But several studies have been done that show there's very high sensitivity and very high specificity for this type of test for transthyretin cardiac amyloidosis with sensitivity of 92% and a specificity of 95%. So we just heard Dr. Kwan brilliantly talk about all the information you can get from a cardiac MRI. This test is a lot less information, but I think the benefit of it is it's a very simple test. It's very easy to interpret. So what you'll see on all reports is the planar imaging or the Perugini score. And really what we're doing here is just comparing the uptake in the heart to the ribs. So a score of 0 means there's no uptake, that's negative. Grade 1 means there's uptake less than the ribs, that's considered to be equivocal. And then grades 2 and 3 are uptake equal to the rib or greater than the rib. Now here at the clinic, we also use SPECT-CT. Most centers just use this planar imaging, and that's all the data that they supply. But we really value the SPECT-CT, and I'll show you an example in a second of why. For the SPECT-CT, what we do is we overlay the nuclear imaging onto a low-dose CT, and this helps us really localize the uptake to the myocardium, which is key. You can see different patterns that all mean a positive SPECT-CT. You can see diffuse uptake with this example here. Some may just have focal uptake, where you'll see single hotspots, or you can have focal and diffuse, where there'll be a hotspot over a diffuse infiltration of the myocardium. Here's a really good example of a negative study. So if you look at the planar imaging, there's no uptake in the heart. And then if you look over and confirm on the SPECT-CT, you see no tracer uptake in the myocardium. Now, the reason why we value SPECT-CT here is because sometimes it's not always clear on planar imaging. You know, it may be hard on this small image, but there's maybe a little bit of tracer uptake in the area of the heart on this planar imaging. Traditionally, at most centers, this would be in that equivocal range where you're not sure. But using SPECT-CT, we can see that that tracer is all in the LV cavity. It's all in the blood pool that just hasn't cleared, but we see no uptake in the actual myocardial wall. So here we can confidently say this is a negative PYP scan. So that brings me to the non-biopsy diagnosis of cardiac amyloidosis. So if you have a positive PYP scan, and then very importantly, I've heard Dr. Hanna stress this 1,000 times, is you must have a negative evaluation for AL amyloid, which includes serum and urine immunofixation and light chains. And I'll show you an example why. So here's a study. This is a positive PYP scan. It's planar grade 2. It's not quite as obvious as the first one I showed, but you can see there's this purple uptake in the myocardium. This is a positive PYP scan. But this person had massively high lambda levels. This was light chain amyloidosis masquerading as PYP positive. And so the thing to note here is that up to 10 to 20% of patients with AL amyloid could have a positive PYP scan. It tends to be more that planar grade 1 or 2, but not usually quite as positive as the people that have transthyretin, but nevertheless, you can get some false positives if you just do a PYP scan. So now I'll spend a few minutes talking about this overlap between transthyretin cardiac amyloidosis and aortic stenosis. So there's a lot of variation in the literature. Some populations were surgical populations, some were exclusively TAVR populations, some a mix of both. But the estimate is between 5 and 20% of patients with severe AS have transthyretin cardiac amyloidosis. I think the important thing to note is these studies were primarily done when TAVR was exclusively for either non-surgical or high-risk patients. So I think the prevalence may change as we expand the use of TAVR, but nevertheless, this is a significant number that could have transthyretin cardiac amyloidosis. The mechanism is not entirely clear. It's thought that the fibril infiltration in the valves can accelerate mineralization, but I think the jury's still somewhat out what the exact mechanism is. So identifying amyloidosis in these patients can be challenging. Here's 2 echoes right here, and both these echoes have thick walls. If I showed you the full echo, they'd have poor diastolic function, they have abnormal LV strain, and it can be challenging to make this diagnosis purely based on echo. But both these patients got a PYP scan, and they had very different PYP scans. This patient A had a planar grade of 0. They have blood pool on the SPECT CT compared to this patient B, who had grade 2 uptake on the planar imaging and a diffusely positive SPECT CT. So the important thing to note here is that despite having similar looking echoes, cardiac scintigraphy is very reliable in differentiating these 2 patients. It's very good at diagnosing cardiac amyloidosis in this subgroup of patients. So I'll briefly go through our experience here at the clinic. We started a program a couple years ago of screening all patients referred for TAVR greater than the age of 70 for transthyretin cardiac amyloidosis with a PYP scan. The prevalence in our cohort was around 4 to 5%. And I think the 2 key points that I took from it, one is you'll traditionally hear that amyloidosis and AS causes low flow, low gradient AS, but only about 2/3 of those patients who were positive had low flow, low gradient AS. So a full 1/3 had what we consider to be normal flow AS. So that in itself, I think, is important to note. What we did find was NT-proBNP was a very sensitive marker for detecting transthyretin cardiac amyloidosis in this population, can be used to help guide who need testing, who don't. So the big conclusions I want you to take from this: 1, cardiac scintigraphy has high sensitivity and high specificity for transthyretin cardiac amyloidosis. Because of that high specificity, a positive PYP scan with a negative evaluation for AL amyloid is diagnostic for transthyretin cardiac amyloidosis. Approximately 5 to 20% of patients with severe AS may have transthyretin cardiac amyloidosis, and this imaging modality can accurately diagnose cardiac amyloidosis in this population. Thank you.
All right, you're all allowed to say it. What's the chemotherapist doing here? So I'll say it for you. But to kind of piggyback on everything that was just said, what is critical in patients with transthyretin amyloidosis or a positive PYP scan is to exclude light chain amyloidosis. The confounding factor with that is when you order monoclonal protein testing for everyone with a positive PYP scan, you're going to find a number of patients who will have a monoclonal gammopathy of undetermined significance. They still have transthyretin amyloidosis. It just makes the diagnostic evaluation a little bit more complicated. So if you take all patients at age 75, a typical age for TTR amyloid, you're going to find an abnormal monoclonal protein test in 5% of those patients. It doesn't mean they have AL amyloid, but again, you're going to have to then do a little bit further workup to truly exclude light chain amyloid, which is a bone marrow disorder. So what I take care of are people with plasma cell disorders, and basically what we're looking at in our blood tests, most importantly, is the serum free light chain assay. Serum free light chain assay in the Cleveland Clinic is listed as kappa lambda free SIR. They cut out the on serum, but kappa lambda free SIR is the test you're looking for. So conventionally, the light chain portion of the antibody was given the name kappa or lambda. Kappa or lambda light chains can cause amyloidosis of the light chain type, but 2/3 are of the lambda type. So again, the big distinction in this evaluation is whether or not the patient has MGUS or monoclonal gammopathy with undetermined significance a benign condition for most patients, and ATTR amyloid, or do they have light chain amyloidosis based upon abnormal lab values? So our laboratory testing is not to order an SPEP and a UPEP. So if you ask even experienced hematologists what tests do they order for evaluation of a plasma cell disorder, many will say SPEP and UPEP, and that's the wrong answer. What we want is the serum free light chain assay, a serum immunofixation, and a urine immunofixation. And actually, we have one test here called a monoclonal protein analysis that will give you the serum immunofixation and free light chain assay. All right, so a couple of cases. These are patients who have a positive PYP scan. In this case, kappa value perfectly normal, lambda value perfectly normal, positive PYP scan. We can exclude light chain amyloidosis. This patient does not need a heart biopsy for a positive PYP scan. This is the other end of the spectrum. So this one is definitely a patient that needs more evaluation for light chain amyloidosis in the setting of a positive PYP scan. Again, there are studies that have been done, and this is a little bit skewed because they did not have a comparator arm with TTR patients, but they took all patients with light chain amyloidosis and did PYP scans, and 20% were positive. So there are certainly a subset of AL patients who will have a positive PYP scan, and in this case, it's pretty obvious that this lambda light chain is very abnormal, and this patient should have some sort of tissue diagnosis made. Now, this can still be a monoclonal gammopathy of undetermined significance with someone who has TTR amyloid. But in this case, either a fat biopsy, some people advocate for salivary gland biopsies, but we're spoiled here in that the cardiologists are very willing to do heart biopsies on these patients to make sure we get the accurate diagnosis. All right, so this one's the harder part. So this patient has a serum immunofixation, or this MPA result, that is negative. So an intact monoclonal protein is not detected. The kappa is abnormal, the lambda is abnormal, but the ratio is normal. And so some people would look at this, even experienced doctors, and say, hey, the kappa to lambda ratio is normal, PYP scan is positive in this case. This patient probably has an MGUS and TTR amyloid. So in this patient, his creatinine was 2, and I'll highlight this in just a second, but when the creatinine is elevated, both kappa and lambda levels will go up. But kappa levels go up disproportionately to lambda. So really, any degree of renal dysfunction, a kappa to lambda ratio of 2, specifically kappa to lambda of 2, is normal. In this case, the patient's kappa to lambda ratio was 0.37. If his light chains were both elevated because of renal dysfunction, we expect his ratio to be 2. And so positive PYP scan, abnormal light chains with normal ratio. This patient had endomyocardial biopsy showing lambda light chain amyloidosis. So again, the PYP scan being positive does not always equate to TTR amyloid. If you remember nothing else I said, that's all I care about. No. This is just to highlight what happens with light chain ratios. And again, our ratios are always listed as kappa to lambda. If you're a hematologist, you should list your ratio as the involved to uninvolved light chain causing amyloid. But in our system, it's always going to be listed as kappa to lambda. So if your GFR is greater than 60, a normal ratio is 0.26 to 1.65. But again, that normal ratio is not always accurate. If your GFR is slightly decreased, again, the ratio can be 0.5 to 2. I would highlight the 2 end of that in a normal patient. And then with a GFR less than 40, Again, the ratio up to 2.25. Some people actually advocate up to 3. And that scenario is a normal ratio. But the bottom line is if you have any question, concerns about monoclonal protein testing that's ordered, please send the patient our way. We'll be happy to evaluate them. But again, even though there is the rare patient with AL amyloid and a positive PYP, the more likely scenario is the patient has a positive PYP, has ATTR amyloid, and just has NEMGUS, and we need to follow that regardless.
So now I'm going to be the counterpart of Dr. Valent, so somebody you're familiar with. From the heart failure perspective, the first thing is to talk about all those red flags that the Dr. Hannah was talking about, because it's very, very important that you identify those patients that have the red flags so you can screen them. So if you see any patient that has heart failure, you get an EKG, you get an echocardiogram, they have low voltage, pseudoinfarct pattern, LVH with at least 1.2 centimeters, intra-atrial septal thickening, biatrial enlargement, the things that you know that are suspicious for amyloid, with also if they have strain available, which not all echoes do, and they have the apical sparing pattern, you have to think of all these other components that make you suspicious for amyloid. So one thing is the age. That's something easy to think about ATTR. So if they're more than 50 years old, more likely it's ATTR, but like we said before, we always have to rule out AL. Family history, sometimes we forget about that, and it's very important. I've asked patients and they've never been asked, and they have 3-4 family members that have had heart failure, aortic valve replacement, a pacemaker placed, and so those things are very important when you put everything together. Ethnic risk, well, if they're Mediterranean, Irish descent, or African American, we know that there's certain variants that are more relevant or more frequent in those patients. The things that we highlight the most, like Dr. Hannah mentioned, is the musculoskeletal part, because when we see somebody with heart failure and they have these musculoskeletal risk factors like bilateral carpal tunnel syndrome, they've had lumbar spinal stenosis, they've had bicep tendon ruptures, trigger fingers, rotator cuff tears, all those things, if you pair them all together in a patient with heart failure, with preserved ejection fraction, mildly reduced ejection fraction, or reduced ejection fraction, you have to make sure that you are suspicious for amyloid and try to screen it to rule it out. Neuropathies, mainly neuropathies in lower extremities, but it can be, pain, numbness, muscle weakness, not necessarily with a diagnosis of neuropathy. Frequently, they have autonomic dysfunction. They have orthostatic hypotension. They can have chronic diarrhea or weight loss because of GI involvement. They have erectile dysfunction. And other cardiac manifestations like aortic stenosis, like we talked about a few talks ago, atrial arrhythmias, AV conduction disease, all those things, when you pair them together, and sometimes they all accumulate, you have to screen for amyloid because those patients are at risk, and we got to make sure that we identify them so we can start them on treatment. So the way I think about amyloid, if I suspect it, is first of all, like I mentioned, the history. You always have an EKG as cardiologist and an echocardiogram. Sometimes you have the privilege of having the cardiac MR. Also, biomarkers. You have an NT-proBNP, troponin that usually we collect. But if you're suspicious, the first thing that you should do is always rule out AL amyloid by checking monoclonal proteins. And like Dr. Valent mentioned, you get the serum, kappa, and lambda light chain, and also the serum and urine immunofixation. And if it's less than 0.36 or more than 1.65, that's considered abnormal. And if it's considered more than 2.3, sorry for the typo there, in kidney disease, then it's something that you have to be worried about. So if that AL lab work is abnormal, then you have to consult the hematologist. The hematologist will help you identify and kind of further stratify what's going on. You have to biopsy the affected organ, and you do staining. Usually we do here immunohistochemistry or mass spectrometry if we need to. And ultimately, that biopsy, like Dr. Valent mentioned, can be a fat pad biopsy. We can do a salivary gland biopsy like they do in Europe, or here we're very comfortable doing endomyocardial biopsies. We're doing echocardiogram and fluoroscopy. We think it's very safe. And if that's positive, then we have the diagnosis of AL, and then our hematology colleagues start treatment. If that AL panel is negative, then we get a PYP scan. What I usually do is I order both at the same time. Why do I do that? Well, the lab work can be done that same day. The patient just goes to the lab and gets all these tests done, and we can have the results in 3 days usually. And then the PYP scan has to be scheduled. And to be able to coordinate everything sometimes is difficult, so that's why I usually order the monoclonal protein testing and also the technetium pyrophosphate scan at the same time, so it can be scheduled and done probably in the next few weeks here at the clinic. So if that is negative, but you still have a high suspicion for ATTR or amyloidosis, you can either do one or two things. If there's some LVH in the echocardiogram, or you're still very suspicious, you can further delineate with cardiac MR, because now it's very sensitive, and we're able to sometimes distinguish if a patient has amyloid, and if we're not concerned because the AL lab work is negative, we can start treatment in those patients. If the cardiac MR, or you decide to go straight to biopsy, the biopsy is positive, then you just have the diagnosis ATTR and you can start the treatment there. Obviously, you have to do genetic testing to make sure that if it's a variant or if it's wild type. If the PYP scan is positive, then you straight have the diagnosis. You do not need a biopsy. You know that it's ATTR. What we recommend is doing genetic testing, and the genetic testing allows us to distinguish between a variant or the wild type. Very important, because if you detect any variant, you have to instruct the patient to tell their family. You have to inform them that there's a high risk there, and that way other patients can be screened and surveilled further down the line. So we have Epic order sets to make this easier here in the clinic. We have the inpatient order set on the right that you get the monoclonal protein testing. We also evaluate the kidneys when we do that, and it's auto-populated to order the PYP scan. Other things you can add in the inpatient setting is an MRI. We always advocate adding the NT-proBNP. The NT-proBNP is used for a TTR staging, and also our Mayo staging with AL and a high sensitivity troponin, because we see a lot of these patients present with a high NT-proBNP, the findings that I mentioned, and also a low level troponin that's been chronically elevated. In the outpatient setting, it's similar. It just looks a little different, but it's the same information, and you can order it just by typing cardiac amyloid, and it'll show up, and you just have to click what you need. In the inpatient setting, it's already even auto-populated. Something that's important is here at main campus, every Monday afternoon in J34, we have a joint hematology and heart failure clinic. In the heart failure side, we have Dr. Hanna, Dr. Finette, Dr. Martin, Dr. Tang, and myself that participate in that clinic. And Dr. Valent is our hematology colleague that is there with us. And the patients that we usually see are those patients either that are very suspicious for AL, or those patients that we think have TTR, but they have abnormal monoclonal proteins. And so we further stratify and understand if they're at risk for AL, if they need biopsy, or what are the next steps to be able to distinguish TTR with AL. So a couple of cases. The first one, 72-year-old Caucasian male, past medical history, had chronic HFpEF, atrial fibrillation, bilateral carpal tunnel syndrome, bicep tendon rupture, lumbar spinal stenosis. And we see this very often. All these things pile up and make you very suspicious. You get an EKG, low voltage in the limb leads, pseudoinfarct pattern. You get an echo, and it has LVH with strain that show an apical sparing pattern. So then you do monoclonal proteins, you see the kappa lambda are normal, the ratio is normal, and then there's no M protein. Do a PYP scan, then you follow it up with a SPECT to confirm, make sure there's no blood pooling. Genetic testing is negative. So this patient you comfortably can say that has ATTR wild type, and you can start them on treatment. On the other side, we have this other patient, 61-year-old African-American male. He had HFrEF with an EF of around 35%, bilateral carpal tunnel syndrome, and you do an EKG, very similar, low voltage in the limb leads with a pseudoinfarct pattern in the precordial leads, significant LVH, and I mentioned that EF was around 35%, very abnormal strain. And then when you do testing, you see that creatinine is 1.8. And back in 2020, they had done serum light chains, and they were already abnormal. With the kappa being higher in the setting of the creatinine, it was not further explored. But then when it was repeated this year, the kappa was 155, lambda was 78, and the ratio was 1.98. the serum M protein, no monoclonal proteins in the serum or the urine. You do the PYP scan, and it was positive. We followed that with SPECT, and we confirmed that. In this patient, because the abnormal serum protein, monoclonal proteins, we were still concerned. We wanted to make sure that we ruled out AL amyloid, so he underwent endomyocardial biopsy. As I mentioned before, we do a hybrid technique with echo and fluoro, and that way we minimize the risk of going to the free wall, causing tamponade, and also making sure the location, so there's no TR and other problems that can arise. This patient, the biopsy was positive for TTR, and then the genetic testing was positive for VAL122 or VAL142 isoleucine, which is commonly seen in African American patients. So in summary, it's considered a rare disease, but is it really? I think we understand now that it's not as rare as we think, TTR. So we gotta, as soon as you suspect it, you got to right away look for it. UPEP, SPEP is insufficient, as we mentioned. We need immunofixation. When you look for TTR, you have to rule out AL, and we have therapies now and hopefully more in the pipeline. So that's very important to identify these patients so you can start them on treatment.
That was really a great way to kind of bring it all together. Before we open it up for questions, I just wanted to mention that we have future ATTR amyloidosis tall rounds. In December, we're going to focus here today. We focus on diagnosis. We're going to focus on treatment and management, and then there'll be a third one in April 2024 on advancements in post-diagnostic monitoring. We do want to thank our partners here, the sponsors who supported this with educational grants. So I think at this point, hopefully we gave you a nice overview and we can open it up for questions.
If we're not in a trial, looking for a trial, why don't we start with the bone marrow and you guys need the endomyocardial biopsy? Do you know what I'm saying? Like when we have a very positive ratio, I'm always like, well, I'd rather do a bone marrow than do an endomyocardial biopsy because I'd like to reduce risk as much as possible. So can you address that outside of a trial situation?
From what I've been told by pathologists is they can't type amyloid from the bone marrow. So doing the immunohistochemistry, there's too much background staining from plasma cells, and there is generally not enough tissue to do mass spectrometry.
If I could interject clinically, if a 45-year-old comes with macroglossia, massively elevated lambda, M protein, bone marrow shows a plasma clone, we see amyloid, technically we can't type it, and the heart looks like it. For me, that's enough. Dr. Valent's one of the few hematologists who will treat in a practical sense. Most hematologists will absolutely say, you got to show me amyloid somewhere, and you need to type it before I give chemotherapy and immunotherapy. But I think there's certain clinical situations where, you can avoid a heart biopsy if the hematologist is comfortable with the information I just stated.
No, and the other confounding thing is we're trying to put everybody on trials now because we have a trial for almost every cardiac patient who's newly diagnosed with light chain amyloid.
So, there's some questions that do come up. I think, one of the big questions is, what is the biggest barrier in trying to make this diagnosis, right? This is what we talked about all day. And I think part of it is that if somebody's on an antihypertensive or has a history of hypertension, one automatically assumes that a wall thickness of 1.3 or 1.4 centimeters must be from that. And they're very commonly, these patients you'll have to de-escalate their blood pressure medicines. I learned that from Dr. Jaber. You just start gradually having to peel them off. But even people with hypertension, I have an African-American female on multiple antihypertensives, and she had a thick ventricle, and I thought, this is very unlikely amyloid, but she had some other markers that suggested it, and she had ATTR amyloid, and she had hypertension. So I think that the biggest barriers is assuming that aortic stenosis or hypertension is explaining everything. If you see anything out of proportion or any other of those red flags, I think you should have a low threshold for pursuing the diagnosis. So I think that the barrier that's one of the barriers.
Dr. Hanna, not to be anecdotal, but just to bring up a case that Dr. Valent and I have dealt with. So Afro-American gentleman, clinical phenotype, amyloid, bone marrow biopsy, non-diagnostic, heart biopsy, read by Dr. Rodriguez as positive for amyloid, but inadequate tissue to type, which we just heard from Dr. Valent related to the bone marrow. Sent for a second heart biopsy. Amyloid only seen on EM, not on light microscopy, inadequate tissue. So we've elected not to treat the patient and to follow him. But how often does this happen?
It's exceptionally rare with TTR in particular. With light chain, there are patients that will have even negative mass spectrometry because of certain mutations in the light chain itself, where the protein does not meet its biochemical characteristic that's normally seen. With TTR, that is exceptionally rare. And there's generally heavier deposition with TTR, but for a non-diagnostic cardiac biopsy, it should be less than 1%.
Thank you. Another question?
Dr. Valent, sometimes we encounter AL amyloid patients when they present with heart failure and actually quite advanced features, and they need to undergo evaluation for advanced therapy, but then, they have AL amyloid in their bloodstream. Can you comment on how the treatment course and advanced heart failure features and potentially heart transplant impacts your plan for chemotherapy?
So if the patient has an early solid organ transplant, it makes it a little bit more complicated because we try and minimize the amount of immunosuppression that we cause in conjunction with the immunosuppression that they need for the organ transplant. We will typically scale back to some degree and see if we can get away with as little therapy as possible. So our standard would be daratumumab, bortezomib, cyclophosphamide, and dexamethasone. We generally will try and start with just bortezomib and the prednisone that they're on for the immunosuppression to see if we can control the clone. Ideally, to be very honest, it would be nice to be able to see a early hematologic response before the organ transplant, because then we can kind of sit and wait. And we've done that, where the patient gets into and our therapy is good. We can get them in, for most patients, a very rapid hematologic complete response. And then if they have the solid organ transplant after that, we just watch until we have to treat them.
Last question,
Walid?
because we
Yeah.
all have to go to work.
Yes.
We see a lot of patients with atrial fibrillation, and there are, on one end of the spectrum, we have the patients who have dilated atria, cardiac amyloid, and they have their own problems. But we have somewhere in the middle a lot of patients with diastolic dysfunction, young patients relatively, reasons that we do not know, big atria, not necessarily hypertensive, big atria. We've sent some of them for pyrophosphate scans and what have you, and turn out to be negative. Is it possible that there is a spectrum and there's an intermediate stage that we are yet to identify in those patients? Is there any longitudinal studies that were done on those patients to see if they eventually develop some form of?
I mean, for me, having been in practice and seeing many of these patients, it always starts with paroxysmal AFib. They've had, and then
Big atria for no reason.
Yeah, I'm not sure about that, but they we always talk about carpal tunnel and spinal stenosis. Well, AFib, then they've had an ablation, then finally we see the thickening and we make the diagnosis. I think you're right. Some of these people, the underlying pathophysiology is probably ATTR amyloidosis and infiltration of the atrium, and they may be at a state where the scan is still not positive. We have thought about, and Wael Jaber has started, and Brian started screening people over the age of 70 going for TAVR with PYP to pick up ATTR. 4 to 5% we're picking up. We had talked about linking up with electrophysiology and finding a cohort of patients with AFib that are seeing you guys who have certain features that we could also screen, that's really ripe for study. I don't think anyone's ever done that. But I think a lot of those patients end up with you guys first. And I see a lot of EPs now starting to diagnose cardiac amyloidosis, including yourself.
But PYP is not good for atria, am I mistaken? Or
I think MRI, to Debbie's point, is a good screening tool. But even if you see fibrosis there, LG, doesn't necessarily mean it's amyloid. But I think that this is very ripe for study, I think.
But I can tell you, when we go in and we map that atria, it's like minimal voltage, low atrial activity throughout.
I think amyloid's on the differential. Yeah.
The issue like that Walid is raising is important, but unfortunately, this applies also to us, to MRI, to everything, is when you diagnose all these numbers about sensitivities and specificities in the high 90s are all from an era where the patients were presenting with advanced heart failure, where you look at the patient, you know they have amyloid. So now you guys are sending us patients with gene positive who are running marathons, doing biking, races, all this stuff. I'm not sure the sensitivity we have is there to pick it up that early. So the question becomes, how often do you screen them? The atrial fibrillation issue is more complex than that, because you're talking about amyloid, like myocardial amyloid with atrial fibrillation. Are you talking about just isolated atrial amyloidosis, which we have those cases? Mazza, you've been involved in the paper we published in Circ Imaging last year with Bat and Muzna. We don't know. And we do not know the sensitivity we have for that. We don't have the spatial resolution of MRI for that. There are many PET agents on the market. They will not be available in the US for 5 to 7 years at least. They probably will help us there. But if I have to just propose like a simple thing like we've done with aortic stenosis, is you take patients with atrial fibrillation, new presentation at any age, unless they have other problems, and you just take a cutoff of pro-BNP. A person with NT-proBNP of 1,000 in atrial fibrillation should not give you that. So if those patients get screened, maybe we'll have a yield of 10, 20, 30%. And you can go from there. That's how I will approach it, rather than just screening everybody and end up being frustrated.
Very good point.
Go to work?
Yeah, let's go to work. Thanks, everybody.